slides here in our lecture, there is a lot of content. So, we're not going to go over every single disorder that's in the chapter in the text. And B, what we are going to cover, we'll cover today in class, but some of it is pretty straightforward in terms of like peptic ulcer disease and those types of things. And some of it is more complex, specifically talking about alterations with the liver, so hepatitis, cirrhosis, etc. So after some thought, I left left the lecture in the order that you see it in the chapter in the book, but to be able to sort of devote the sort of correct amount of sort of brain energy on it, I want to make sure that we really spend time today while we're together, in person, really make sure we spend a lot of time talking about the liver stuff, because I think that's more complex, and I really want to be able to have some time together to spend on that. So we're actually going to jump to the liver content of this lecture, which is slide 29. And we're going to actually start with the liver stuff first today. Then whatever time we have left, we'll go back to the beginning of the lecture and kind of start with some of the more straightforward stuff. But I really want to do liver first while we're fresh and while we have ample time to spend together talking about it. Does that make sense? There really is a method to my madness today, I promise. Okay, so we're going to start talking with liver, specifically hepatitis first this morning. So we'll start with viral hepatitis. So as the name suggests, obviously hepatitis is inflammation of the liver. It's a systemic sort of viral disease, so it is a virus that primarily affects that particular organ. There are different strains of the virus that certainly cause different types of hepatitis, and you see them here. But no matter sort of the type of hepatitis we're talking about, the symptomatology and the pathophysiology, no matter if you're talking about Hep A versus Hep C, is very similar. So when we talk about the pathophysiology of viral hepatitis, we can sort of cover all of the different types of hepatitis in that conversation, and it's all pretty similar. So let's talk a little bit here regarding the different forms or the different types of viral hepatitis. So the first one is hepatitis A, and we'll kind of go through each one of these more specifically, but here's kind of a list for you. Formerly known as infectious hepatitis, and we'll talk about why it's been known as infectious hepatitis in just a little bit. There really is only one form of hepatitis A, and it's acute. So by that, what I mean is there's an acute sort of disease process, and then it's self-limiting, and it goes away. There is no chronic implications of having Hep A. And we'll talk about that more specifically in just a second. As opposed to Hep B and Hep C, which are more formally known as sort of your serum hepatitis, in that it is bloodborne. It is sort of carried in the bodily fluids of people with this particular type of hepatitis, both B and C. So IV drug users, IV blood transfusions, sexually transmitted, those types of ways is the way that B and C gets transmitted. Both of these forms of hepatitis have an acute form, but they also can then sort of lay dormant or sort of lay quiet for a long period of time in people, and then sort of decades later can sort of rear their ugly head and cause more of a chronic condition in people who have been infected with B and C. And we'll talk more about that more in just a second specifically. And then the last form, which we're not going to spend a lot of time talking about today, but it's just sort of interesting, Hep D depends on the presence of hepatitis B virus for its replication. So a patient cannot get Hep D unless they've already been infected with hepatitis B, unless that virus is present. So just kind of like an interesting little side note there, that you really cannot get a Hep D infection with not already having hepatitis B. All right. So let's talk about the patho of hepatitis generally speaking, and then we'll talk more specifically about each one of these forms. So the general pathophysiology, what happens in hepatitis? Well, we've already said it's inflammation of the liver cells themselves, so those hepatocytes that we talked about on Thursday. So not only can it cause those cells to die and become necrotic, so causing hepatic cell necrosis, especially in the more chronic forms like you would see in Hep B and Hep C, you can actually see some scar tissue and some sort of sclerotic tissue forming in the place of those dead hepatocytes. So obviously you can imagine, scar tissue does not function like normally healthy cells. So you can see a lot of liver dysfunction, especially if there's scarring that's going on there in the organ. You will also see Kupffer cell hyperplasia. In my voiceover PowerPoint from Thursday, I discussed how Kupffer cells play a big role in sort of the immune function of the liver and also in the sort of liver cleansing role that Kupffer cells have, and that they sort of filter out and get rid of old, destroyed, non-functional red blood cells. So again, you'll see hyperplasia of those specific type of cells. And with this inflammation that you would see in this organ, not only can it obstruct those bile ducts, those small little ducts, the canaliculi that we talked about on Thursday, but they can damage and obstruct. So you can imagine, right, if these little canals that the bile is supposed to be, flowing through after it's formed, after it's made in the liver, if there is a lot of inflammation and obstruction going on in those canals, what do you expect might happen? Pathophysiologically speaking, but then also so clinically speaking. What do you think you would see with inflammation of the canaliculi? What do you think? It's up here on the screen if you know what some of those words are. Cholestasis. Anyone know what cholestasis is? It basically means just stasis of the bile in those tubes, right? So if there's inflammation, there's going to be a sort of a slower flow of the bile through those canals. And what happens if the bile is moving very slowly or very sluggishly through those canals? What do you think might happen or could possibly form? Gallstones. Very good. So with cholestasis, you can obviously then start to form enough sludge and enough sort of obstruction there that you actually start to have cholelithiasis, which is actual gallstones. Good. And then obstructive jaundice. And the reason that you would see jaundice here is that if those canals are obstructed and the bile is not adequately flowing and dumping into the duodenum, into the GI tract, like we talked about on Thursday, you just have a backlog of bile just building up, building up, building up, building up inside the liver and not actually getting deposited where it needs to go. So if it's not getting dumped in properly into the GI tract, where does it go? What happens to it while it's sitting there sluggishly, just sitting there in the liver? Anyone know? It actually starts to get reabsorbed into the bloodstream in the liver. So obviously, if you've got an increase of bile and bilirubin products building up in the blood because it's not able to get dumped properly into the GI system, what do you see clinically in your patient? Jaundice. They start to turn yellow because of the increased bilirubin content in their blood because it's not in their GI tract, now it's in their bloodstream, right? And so we call that obstructive jaundice. This is where you start to see yellowing of the skin, of the whites of their eyes, of their mucous membranes because of this obstruction in the bile ducts because of the inflammation. Hope that makes sense. And then obviously, in more severe cases, like sort of the more severe viral strains of hepatitis, like in Hep B and Hep C, a lot of this damage is even worse. It can be, the severity can sort of depend. So you'll probably see more pathophysiology in like Hep B and Hep C than you would in, say, Hep A. So just sort of generally speaking, that's something to sort of keep in mind. Okay. So that's the general patho of hepatitis. Any questions about that before we get more into the specific types? Okay, good. All right, so the first one, Hep A. So Hep A, as I mentioned, is sort of known sort of historically as more of the infectious hepatitis. This virus can be found in feces, in bile, and a little bit in the bodily fluids of the infected individual, but mostly we think about Hep A as sort of being transmitted by the fecal-oral route. So that is to say, someone comes into contact with feces that's infected, gets on their hands, they then prepare food, feed their children, whatever it may be, eat themselves, and that's how it gets transmitted. So fecal-oral route. Luckily in the United States we don't see it all that often because it often does happen more in more crowded, sort of unsanitary conditions. Also happens a lot when food and water contamination is present, like in more developing countries that sort of have non-potable water that people are going ahead and drinking and things like that. So we don't see it a ton here in the United States because of that particular way that it's transmitted, that particular route. But you certainly see it more in developing countries, and you can honestly sometimes you'll hear about outbreaks occurring here in the United States, even in like daycare centers. again, because all that diaper changing is going on. There's so much sort of going on, someone's changing a diaper and then they're going and preparing food or bottles or whatever it may be without proper hand washing. And so you do see sometimes, you see some outbreaks going on in centers or in places like that, but pretty rare here in the United States. You know, we know as healthcare providers, we don't necessarily have to have a Hep A vaccine to, you know, provide care in, you know, healthcare centers or in the hospital the way we do like with Hep B. But if you ever do any sort of work in developing countries, you will need a Hep A vaccination. I know when I did some work in Honduras, I needed to get a Hep A vaccine. But it only lasts for a couple of years, so you would need to sort of redo it every so often if you're in, you know, areas where that's a risk. But again, that's kind of the general background or the basis of Hep A. All right. Hep B, now this is different, right? We said already that this is how it's transmitted through infected blood, body fluids, contaminated IV, you know, hypodermic needles, things like that. So you see it a lot in populations of people, like I said, with high-risk sexual practices, sharing needles, IV drug users, those types of populations. You see Hep B and Hep C more frequently in those populations. Also, you can see some maternal transmission from mom to baby with Hep B, especially if the actual transmission, or I should say the actual infection, occurs late in the pregnancy. So in the 3rd trimester or so, if someone is infected, it is possible for that virus to cross that placental barrier from mom to baby. But again, as healthcare providers, you know that there is a Hep B vaccine, that, you know, that series of 3 that you have to get to be able to work in healthcare centers, that totally, you know, blocks the development of Hep B, even if you come into contact with that virus. Interestingly, people with Hep B can not even necessarily know they've had it, right? They can be completely asymptomatic. Or they can kind of have the general kind of malaise that comes with the virus, you know, nausea, vomiting, fatigue, headache, that type of thing. And then it completely goes away with, again, no sequelae, no fallout, no, you know, they can live a completely normal life after that particular infection. And then, you know, not only if you get the Hep B vaccine, or if you've actually had hepatitis B, you then know that you have lifelong immunity after that. So that's one sort of positive thing about Hep B, is that you do have immunity after you actually have the disease. And then, of course, obviously, if you've had the vaccine as well. So again, to be clear, hepatitis B, if you have it, can go completely away with no lingering side effects for the rest of your life. And if you look here at the bottom of the screen, there is a very, very small percent of people who get infected with Hep B that actually go on to have more chronic hepatitis, where, you know, they have more lifelong chronic disease because of this particular infection. So really only 6% of people who have an acute hepatitis infection will go on to have more chronic health issues and chronic liver problems down the road. Hope that makes sense. Keep that in mind, because it's very different than Hep C, which is about that percent is very different, which is what we're about to talk about. All right. So Hep C, again, very much bloodborne type of transmission, just like Hep B. Interestingly, especially here in our country, Hep C is responsible for a lot of cases of people who got hepatitis because of blood transfusions. Now that's really scary if you think about, but let me tell you this. The population of people who have a high percent of being sort of infected with Hep C is the older population. So in our country, the baby boomers have a really disproportionately high Hep C rate in that particular generation than in other generations. Anyone know why that is? Again, with this connection between blood transfusions. Anyone know why that is? Go ahead. Right. The proper screening for Hep C in blood, you know, donations really wasn't up to speed and totally providing coverage of screening for hepatitis C until the early 90s. So anyone who got a blood transfusion prior to the early 90s, which again, you know, baby boomers were sort of early adults at that time, are at higher risk of developing Hep C because of, you know, if they've had a blood transfusion, because of the lack of adequate screens at that time. So it's really interesting. You see, like I said, a higher proportion of hepatitis C in the baby boom population or generation. And then look here at Hep C. Very, very different percentage of the amount of people who get Hep C who go on to have more chronic hepatitis C. So 50 to 80% of people with hepatitis C cases result in more of a chronic hepatitis. So if you're going to think about sort of the severity of these hepatitis that I'm talking about, Hep C is probably your most severe. It's probably the hardest and most debilitating to those hepatocytes and to the tissue of the liver in general. And therefore, you see more chronic health issues occur in people with this particular virus than in the other forms of hepatitis that we've talked about. They do have a chance, people who get infected with Hep C certainly do have a chance of sort of living that normal life without, sequelae afterward. But there's less of a chance with that high percentage. Yeah, Megan. Oh, yeah, yes. The chronic forms, yes. Someone actually brought that up last year when we were talking about this because it was super, super new at that time. They had a family member or a father or someone who had done that. So that's true, and I need to actually update my slide with that. That there is a new, is it a vaccination? Is it an injection? A pill, okay. Right. Right. So the people who have had chronic Hep C, this is my understanding, the people who have had chronic Hep C for a long time and have undergone a lot of other treatments, it's not as effective for them as it is for people who sort of the first go at treatment. Yeah. Yeah. Just like any new drug. Right. Yes. Yes, there are programs and, payment options and that type of thing. And is it Harmody? Arvodi. Okay. Yeah. So that's just kind of a sort of background of hepatitis C. And you're right, I do need to update my slide because we actually had that same exact conversation last year about that. Thank you for adding that. Okay. And it is also possible for people to have both Hep B and Hep C. And I've had a lot of patients in the emergency room that are both Hep C and Hep B and Hep C. Again, most of the time because of the lifestyle perhaps that they have lived, IV drug users, et cetera. It's not uncommon for them to get both viruses. All right. So no matter what the type, no matter if we're talking about A, B, C, whatever it may be, the clinical manifestation sequence of an acute infection is very similar. It's basically the same, and there's 3 phases, so to speak. So there is the prodromal or pre-icteric phase. Anyone know what icteric means? So therefore, you would know what pre-icteric means. Anyone know what the icterus or icteric means? It means jaundice, right? So icterus means that the person bestows jaundice. So the prodromal or pre-icteric phase is the phase before someone becomes jaundice, right? So this begins about 2 weeks usually after the exposure to the virus, and really then does end when the patient appears and becomes jaundice. So again, this can be hard to know that there's anything wrong with you during this phase, right? It's just kind of the normal signs and symptoms of maybe, the flu or a bug or just sort of that general malaise that you might have. So fatigue, loss of appetite, perhaps some nausea or vomiting, maybe a low-grade fever sort of associated with a headache, right? I mean, who hasn't had any of that in the last, couple of months, right? So it's kind of hard sometimes to know that that's what's going on pathophysiologically. And what's truly scary about that is that during this early phase, this prodromal phase, is when the person is most highly infective, right? So you're most infective during this phase where you don't even know you have something, which is the scary sort of public health aspect of that particular phase, is that you can be out infecting people because you don't even know that you're sick in the first place. So that's kind of the scary part about this highly infectious sort of prodromal phase. Then once the person becomes jaundice, this is what we call now entering into the icteric phase, right? And this usually begins about 1 to 2 weeks after that initial prodromal phase began, and it can last a while. It can last a couple of weeks, it can last a month and a half, it can maybe even last a little bit longer than that. And what you will see not only during this phase is not only the jaundice, but you'll also see some other very classically characteristic sort of signs and symptoms of this phase when someone's jaundice. And that is very, very dark urine. I mean, looking like iced tea or, Diet Coke. And clay-colored or lighter-colored stools. Now, given the pathophysiology of what we had just talked about in terms of that obstructive jaundice that we talked about on that pathophysiology slide, why might that be? Why might you see dark urine and light-colored stools in someone with hepatitis who's jaundiced? What do you think? Put the pieces together a little bit here for me. What do you think? Yeah. Right. The excess bilirubin where? In the blood. Exactly. So you're seeing, because you have that obstruction of bilirubin not making it to the GI tract and getting backed up and sitting in the liver and then being reabsorbed into the blood, right? What you then see is that increased bilirubin in the blood. And then where does the blood go? It filters into the kidneys, right? And you actually will then see that darker urine being produced in the kidneys because of that increased bilirubin in the blood that then got filtered by the kidneys. Does that make sense to you? Yes? Okay. So then, if all the bilirubin is backing up into the blood and being filtered and sort of excreted out in the urine, why would you see light-colored stools? Because it's not going into the GI tract, right? And it's bilirubin that gives our stool that characteristic brown color, right? So if you've got a lack of bilirubin in the GI tract and in the stool, your stool looks very, very light, sort of this gray, clay color appearance, right? So if you see someone who's jaundiced, it is not, especially acutely jaundiced, for this particular reason, it is not abnormal to see very dark urine and very light stools. I hope that pathophysiology sort of puts the pieces together of why you see all three of those things in combination. It's during this phase as well that the liver does become really inflamed and enlarged. It can become very sort of taut and distended. So obviously if you would actually look at the liver during this time, it's got a very sort of tight, shiny, smooth appearance to it, and obviously is very tender especially upon right upper quadrant palpation during your assessment. This is what we sort of note as the actual sort of phase of illness. This is when someone appears sick, their lab values are out of whack, they're having these changes in their skin, in their urine, in their stools, etc. This is sort of the actual phase of hepatitis, the illness, so to speak. All right. Then, as you move through that icteric phase, we move now into the recovery phase. And again, this can really vary. It usually begins with some sort of resolution or the decreasing of the jaundice, which happens about 6 to 8 weeks, at least starting around 6 to 8 weeks after exposure to the virus itself. Symptoms then sort of begin to diminish. Those icteric symptoms kind of start to resolve. But the liver can still remain very enlarged and quite tender, again, with assessment for a long time after that, even if the other symptoms are kind of going away. And liver function tests, like if you actually look at their liver function in the blood work, can return to normal about 2 to maybe sometimes several months down the road after initial jaundice onset has sort of set in. But again, what I want to be clear about in terms of these three phases of hepatitis is that there really is a spectrum of manifestations. So they can range anywhere from, as I mentioned, to being completely asymptomatic and not even know that you've been infected with one of these hepatitis, or all the way to fulminant, what we call fulminating liver failure, which can be very rapid onset, diminishing function of the liver, turning into liver failure, coma, death, etc. So there really can be a wide range of clinical manifestations of viral hepatitis. I want to be really clear about that. And any sort of acute cause, so any acute infection of a viral hepatitis will certainly cause the abnormal liver function test. So their liver function will look strange. Their liver enzymes will be elevated with an acute viral hepatitis. Okay. All right, we're not going to spend a lot of time on this slide. I just want to kind of briefly mention it in terms of how do you diagnose, how do you evaluate, how do you treat. Evaluation, basically, you diagnose both Hep A and Hep C based on presence of the antigens, right, and the antibodies in the blood. Hep B is a little bit more complicated, and again, we're not going to spend a lot of time on it today, but there are a lot of serologic analyses that are done for specific virus antigens. So, for example, with Hep B, it's possible to have certain antibodies elevated even if you haven't had Hep B, but you've been exposed to the virus. So there's core antibodies that can be elevated. Again, means you've been in contact with it. You may not have just come out with full-blown Hep B. And there's some other, antigen-antibody combinations that kind of tell the diagnostician, have you actually been infected with Hep B? Have you just come into contact with Hep B, etc. So that's kind of the background there about evaluation. Treatment, Hep A, I mean, Hep A is just like a virus, right? It's self-limiting. You just kind of have to let it run its course. So there's a lot of sort of symptomatic support and symptomatic treatment for Hep A. Hep B and Hep C are a little bit different. We mentioned the new medication that's used for Hep C. Hep B, oftentimes they will use other types of medications to kind of interfere with viral replication. Remember, we talked about at the very beginning of last semester the use of interferon with viral infections, and that interferon oftentimes will help stop or at least interrupt viral replication. So they'll oftentimes use interferon for Hep B infections as well to kind of try to slow down or at least block a little bit of that viral replication that's going on in the body. But again, not going to spend a ton of time on that. Just didn't want to leave the conversation of this before we sort of talked a little bit about treatment. Okay, any questions about that before we move on to our next slide? Making sense for you a little bit? Okay. All right, the last slide regarding hepatitis, before we move on to our next topic of cirrhosis, is this issue of fulminant hepatitis. Now, fulminant hepatitis is a little bit different than sort of these acute types of hepatitis that I just talked about. With fulminant hepatitis, another sort of way you can think about it, or another term you could use for fulminant hepatitis, is acute liver failure. Okay? Rarely occurs in someone who's been infected with Hep A. Just doesn't happen. The severity of that particular virus just isn't as hard on, or as toxic, should I say, to those hepatocytes. And you really don't see even really a remote chance of liver failure with someone who has Hep A. Now, certainly occur more commonly as a sort of a complication of someone who has been now infected with Hep B or Hep C. So you can see the liver actually start to fail with some severe cases of Hep B and Hep C. Another situation, clinically speaking, that you may see fulminant hepatitis, or again, another way you can think about it is acute liver failure, is with some sort of toxic reaction. So a big drug that you actually might see causing acute liver failure is Tylenol, acetaminophen. Acetaminophen is very much filtered and sort of metabolized by the liver. So any overdose, and by overdose of Tylenol I mean, usually about a gram of acetaminophen in like 6 hours is the max dose that you should do. So I've seen people who have taken 2, 3, 4 grams at one time. They are certainly at risk for putting themselves into acute liver failure with that dosage of Tylenol. Again, because it's very toxic to those hepatocytes, because that is where Tylenol goes to sort of be excreted and filtered through the blood. So again, keep that in mind when you're thinking about toxic drug reactions that might cause someone to go into acute liver failure as well. The pathophysiology of acute liver failure is the hepatocytes become edematous, and you will actually start to see little areas of actual necrosis to the liver tissue and necrosis to those hepatocytes that obviously disrupt the role and sort of the functioning of the liver tissue. With those deaths or sort of the dying off of those hepatocytes, you can also, either because of viral reasons or because of some sort of toxic reason like Tylenol, you'll start to see obviously immunologic changes occurring as well, because you're killing off some of those Kupffer cells and some of that immune function of the liver as well. Clinical manifestations of acute liver failure, or again, aka fulminant hepatitis or fulminant inflammation of the liver, you'll really see start to develop within 6 to 8 weeks after initial symptoms. So 6 to 8 weeks after someone sort of starts to have either Hep B or Hep C kind of viral symptoms, or 6 to 8 weeks after someone has maybe overdosed on Tylenol, right? Whatever is the sort of the leading cause of the damage to those hepatocytes, it's kind of a delayed response of when you actually start to see the liver really start to fail. And again, this does not always happen in someone who's been infected with Hep B or Hep C, but it can certainly be a complication of someone who had a pretty severe infection of Hep B or Hep C. What you'll start to see is, again, a lot of sort of systemic type of manifestations. So loss of appetite, vomiting, pretty severe right upper quadrant abdominal pain. You'll start to see that liver function rapidly decline, so you'll start to see more progressive jaundice occurring in these patients. And then really what you'll start to see as the liver functions go down the tube, so to speak, is you'll see a lot of complications of liver disease or liver disorders, which is what we're going to talk about in just a couple of minutes here. But again, this does not always happen. This is on that spectrum, that spectrum of, someone being completely asymptomatic with some type of hepatitis to having a very severe sort of loss of hepatocytes with an infection. So I just want to be clear about that. Let me finish this slide, and then I think there was a question over there I'll be happy to answer. So treatment of acute liver failure or fulminant hepatitis. Unfortunately, the necrosis of these hepatocytes are pretty profound, and so oftentimes a lot of this is irreversible. So as you're losing liver tissue and as you're losing this hepatocyte because of whatever toxic reaction is occurring, it can get pretty complicated and pretty hard to turn around. So a lot of the treatment is very supportive. And oftentimes, if there's so much hepatocyte damage, these are people who are actual candidates for liver transplantation because you just can't turn around the sort of pathophysiological effects of this rapidly declining liver function. Acutely, though, I will tell you that especially like in the emergency room, if we know that someone has come in for a Tylenol overdose, let's say, there are some things to try to do acutely to try to decrease very quickly after it has occurred to try to decrease the acute damage of, say, like a Tylenol overdose, but it's extremely time sensitive. So a couple of the things that we would see or that we would do in the emergency room of someone who has overdosed on Tylenol. And unfortunately, some of the reasons, so to speak, for why someone would overdose on Tylenol would either be, one, they didn't understand the dosage, so they just, very sort of benignly took too much Tylenol, which is really unfortunate, or a medication that had Tylenol in it. They didn't necessarily know there was a lot of acetaminophen in, like Percocet, and then they took Tylenol with Percocet or something like that. Another reason that I honestly see it in the emergency room is that someone was suicidal and tried to commit suicide by taking a lot of medication that had a lot of Tylenol in it. Unfortunately, or fortunately, however you want to sort of look at it, it doesn't do that, right? Doing an overdose of Tylenol doesn't necessarily mean that this person's going to, go to sleep and not wake up. Unfortunately, what ends up happening for these people is that they end up having complications and maybe dying down the road because of liver failure, because they just totally did in their liver with taking all of this Tylenol. Either way, one way or the other, acutely, acutely, when they come into the emergency room, we know it's a known Tylenol overdose, there are a couple of things we can do. One, there is an IV antidote to acetaminophen called Mucomyst. I'll write that here on the screen. Mucomyst. Yes, Mucomyst. It's an IV drip that, like a toxicology expert would sort of titrate out according to their weight and the dosage of the Tylenol that they supposedly took. And it actually ends up binding to the excess Tylenol in the serum, in the blood. Another one that we do quite often in the emergency room is activated charcoal. Anyone familiar with that? It basically is like liquid form of charcoal. I mean, it is a resin, a liquid that they would then drink that's like literally black as night. It looks like you're drinking liquid charcoal, literally. It's a resin that then binds to the excess acetaminophen in the gut and binds to that excess Tylenol, and then they end up excreting it out through stool, through their GI tract. Again, unfortunately, oftentimes the IV Mucomyst is pretty easy to start and pretty easy to do, but unfortunately the activated charcoal, they have to drink it. So I've had so many times in my ER life that someone's coming in perhaps because they were suicidal and they tried to commit suicide, and clearly it didn't, I don't know how to say it, but their efforts did not achieve what they were trying to accomplish, and so they're very upset. They're mad. They're upset about the whole situation. It's very difficult to get someone who's feeling that way to adhere to sort of drink this lovely black liquid and bind this Tylenol. So oftentimes we're putting down NG tubes and actually inserting it through syringe into their stomach to get this charcoal in to start binding to this excess Tylenol. I had a woman one time who had done exactly that in the emergency room in St. Louis, who, I mean, she was pissed, right? I mean, she didn't want to be there, right? So she's pissed that we are trying to do all this stuff to try to bind to this excess Tylenol. She's spitting this charcoal all over the room. She's thrown it on the walls. She's thrown it at us. And literally, it's time sensitive. So we're trying to be as supportive as possible and say, you know, you've got to get this in. The sooner we get this in, the more excess Tylenol it binds to. And I remember one of my ER attendings that I was working with, you know, we're both in the room with her getting spit on and all of this stuff, trying to get this charcoal down. And he literally just gets so fed up and tired with her that he says to her, "Tick-tock, time is liver," and just like walks out of the room. Thanks a lot. So now I'm stuck with this lady who's already pissed off at us. You've just said this, and now I'm stuck here with her trying to get her to take this. But he's true. Tick-tock, time is liver. In terms of like saving these hepatocytes and getting these supportive measures in to try to decrease that overall Tylenol level. So again, just kind of trying to bring that more clinically to life for you. Okay, a couple of questions. We had a question over here, and then I'll get you, Taylor. Yeah. Yes. Yes, it is. It is. And so they actually give that IV as an antidote for acetaminophen. Yeah, yeah. Mm-hmm. Was that the question over there? Was there somebody else? Did you have a question? Okay, okay.
If you overdose on acetaminophen, do they always know, like, are there other symptoms that indicate that you've just, or?
Not necessarily. Yeah.
And then,
later on down the road, weeks down, months down the road, they start to go into fulminant acute liver failure. Yeah, yeah. One more question. Yeah.
How different is the sorbitol that they mix with the activated charcoal as far as, I mean, is it easier for them to take
than just the straight charcoal? Perhaps. It just depends. Honestly, in my experience, it's more about their disposition of how easy it is to get this activated charcoal in versus what it's given with or how it assists with, you know, the actual. I remember one time in the ER, I was giving it, about sort of mixing it up, about to give it to someone, and one of the residents that I was working with said, like, "Have you ever tasted that?" And I said, "No." And he's like, "Try it." So of course I did. It doesn't have a terrible, I mean, it's not, it didn't gag me. You know, like I was able to sort of to try it. So I mean, there really is no huge contraindication to actually getting it down. People just don't want to get it down because of what other more, you know, psychological issues that are going on with that at the time. Yeah.
So when you were lazy, you just went straight to the
Just doing the IV. Yeah, yeah. Especially with children. Yeah. Right. No, especially with children, I can imagine that. Sometimes we're a glutton for punishment in the ER, I guess. All right. Any other questions about acute liver failure before we move on to cirrhosis? Hope that makes a little bit of sense to you. Okay. All right. So now, I want to be clear as we move from the conversation of hepatitis. What's the plural of hepatitis? All the hepatitis that we just talked about. Hepatitis, I don't know. The plural of hepatitis, whatever that is. I want to be clear as we move from that conversation of hepatitis to cirrhosis, is that cirrhosis is a little bit different than hepatitis in that it is an irreversible inflammatory process of the liver that's almost like a syndrome, so to speak, of inflammation of the liver that can be caused by infections or some other type of disorder. So to be clear, prolonged sort of chronic infection of some of these hepatitis that we talked about would then ultimately cause cirrhosis, right? So I want to be clear about that. Cirrhosis is more of this sort of general syndrome of the breakdown of the liver tissue, perhaps because of a sort of primary reason, perhaps like hepatitis, okay? So it's an irreversible inflammatory fibrotic disease of the liver that obviously disrupts liver function and really disrupts the structure of the liver. So structural changes that result from some type of injury to the cirrhosis or an injury to the liver, like I said, like a hepatitis or something like that. So it leads to injury and fibrosis or sort of sclerotic scar formation in the liver. The way that I sort of think about cirrhosis is that the liver has been broken down for some reason. Maybe because of hepatitis, maybe because of some other confounding thing like alcoholism or something like that, right? For whatever reason, the liver has been broken down, and now it's trying to build itself back up, and it's really bad at it. Okay? So this is how I think of it. Think about if I had this huge pile of Legos here, and I asked this very talented architect to build me this beautiful tower, to build me this beautiful castle, right? And this very talented architect builds this beautiful Lego structure, right? Then I tear it down. Then I ask my 4-year-old son to come in here and build it back up. Do you think his tower is going to look like that architect's tower? No, right? And that is exactly, it's going to be all structurally awful, right? Disorganized structurally, not functional, looks like crap, right? And that's exactly what cirrhosis is. Something has broken the liver down, maybe alcohol, maybe hepatitis, whatever, and now the liver is trying to build itself back up, and it's really bad at it. So structurally, it's a mess. It's scarred. The function is terrible. The structure is terrible, and that is what cirrhosis is. Okay. You'll see decreased liver function because of the structural changes. You'll see blocked bile ducts. You'll see blocked blood flow because of the abnormal structures going on in the liver. You'll see dead hepatocytes or failure of those hepatocytes to sort of flourish and live. And it really is a leading cause of death in the United States. Again, for whatever reason, initially caused that damage to the liver. Cirrhosis ends up being the secondary sort of problem or the secondary syndrome, so to speak. So a lot of disorders can cause cirrhosis. Hep B and C and alcohol probably being the highest reasons for cirrhosis formation in the first place. But anything that breaks down the liver can ultimately end up causing cirrhosis. And the reason that alcohol is a high sort of risk factor for cirrhosis is that the alcohol byproducts are very toxic to the liver. Again, that is where alcohol is filtered, metabolized in the liver, and if it's in excess, it just sort of tears down those hepatocytes. Okay, so again, the pathophysiology is kind of exactly what I just said. It's very chaotic in terms of its structure. So the chaotic fibrosis alters and obstructs the biliary canals. It obstructs blood flow. It obstructs those canals, so you'll see, again, obstructive jaundice. And you'll see portal hypertension. Remember, the portal vein is that vein that drains the blood from all of the other GI organs in the body into the liver, right? We talked about that on Monday. So you'll start to see a backup of blood and sort of hypertension in that vein. Why would that be? Why would you actually kind of start to see portal hypertension and basically increased pressure in that vein with cirrhosis, given what I just said pathophysiologically speaking? Why do you think that is? Mm-hmm. Yeah. I mean, you've got inflammation and you've got hardened sclerotic changes occurring, so you're not going to be able to have the liver basically accept that blood through the hepatocytes and be able to sort of filter that blood the way it should under healthy circumstances. So you basically just see the blood back up, and you start to see the blood back up into that vein. Good. So blood can be shunted away from the liver because of that. Obviously, if blood is being shunted away from the liver, you're going to see necrotic, sort of lack of blood flow changes to those cells. And then again, this process of, instead of regenerating, what you get in its place is hypoxia, necrosis, obviously atrophy then, because you're getting lack of oxygen and nutrients to the liver, and ultimately liver failure. This fibrosis and this funky regeneration that occurs in cirrhosis actually causes the liver to look very sort of noduly and kind of cobblestoney, very bumpy, visually looking at the liver. So it gives us this very sort of cobblestone appearance to the liver. And I'll show you a picture of that in just a second. So early manifestations of cirrhosis, again, look kind of the same as all the other liver stuff we've already talked about this morning. You know, loss of appetite, nausea, vomiting, malaise, right upper quadrant pain, fever, weight loss, etc. Late clinical manifestations, so after someone's really progressed into a very sort of severe pathophysiology of cirrhosis, we'll see what I essentially call here is complications of liver disorders. And we're going to talk about all of them specifically in just a second. So you've got your early clinical manifestations, they're listed there for you, of cirrhosis. And then you've got late clinical manifestations, which I'm about to talk about more specifically in just a second. So that's kind of like a little footnote there for you. And we're going to talk more specifically about each one of those in just a second. Okay. So cirrhosis can develop very slowly over a period of years. The severity and the rate of progression really does depend on the cause. If toxins like alcohol, for example, are involved, the rate of cell death and the rate of sort of the severity of the inflammation really does depend on the amount of toxins present. So that is to say that if you've got an active alcoholic who's actively drinking, the cirrhosis might actually progress faster than someone who maybe is a recovering alcoholic who's done considerable damage to their liver but is actively not currently drinking. The progression of the cirrhotic changes to the liver might be a little bit slower than someone who's actively abusing alcohol, for example. So clearly removal of the toxin does slow down the progression of the disease. So someone who has then quit drinking is obviously at a little bit lesser of a chance of the progression of that disease process from occurring. So just to be clear about that. Okay. Again, here's this picture that I was sort of showing you. So here's your normal liver of what a normal patient's liver would look like. And here is this nodulary, cobblestoney, bumpy appearance to a liver of someone with, a pretty severe syndrome of cirrhosis. So again, you can imagine that blood flow is altered through this thing. The bile channels are altered through this thing, and you're causing a lot of these more major sort of liver disorder complications if someone's liver looks like this as opposed to this. Okay. Here's a flow sheet of some of these liver disorder complications. We'll talk about a lot of these more specifically, but I just kind of included that in here for extra reference. Okay. Let's talk a little bit about these complications of liver disorders. Again, we talked about the early manifestations. Now, let's say we've moved through these early manifestations of cirrhosis, and now this person is getting sicker and sicker and sicker. Their liver function is declining. Now we might start to see some of these signs and symptoms or clinical manifestations of pretty profound cirrhotic changes to the liver, or as I'm calling them, complications of liver disorders. Okay? And here they are for you. Portal hypertension, hopefully that makes a little bit of sense to you. Ascites, something called hepatic encephalopathy, jaundice, which we've talked about already, and hepatorenal syndrome. So all of these are basically like accessory organ disorders, right? So this can be either, because of sort of acute or chronic liver disease that leads then to more sort of significant systemic life-threatening complications. And I will be honest with you, some of these patients with these very profound complications of liver disorders are by far some of the most sick, some of the most scary clinical situations that I've ever had in the emergency room. I mean, these people are sick as all. You know what? And let's talk a little bit about why. Let's talk about how this systemically affects them and why they are so stinking sick when they come into the emergency room. All right. Again, probably because of some sort of hepatitis or alcoholism or something like that. Okay, so the first one we're not going to spend a ton of time on because I hope I've kind of made this patho clear to you in terms of portal hypertension. But basically, an abnormally high pressure found in that portal venous system, draining from all of those GI organs into that one portal vein that goes into and filters into the liver. Again, we have already said why, because it's caused by resistance to that portal blood flow, because of that inflammation, because of that sclerosis, because of that hardening of the liver. It's just not accepting the blood. It's not accepting that good, healthy blood flow. Again, you see why. So because you've got thrombosis, you've got inflammation, you've got shunting of blood, etc. is why you see the portal hypertension. Those small little capillaries that we talked about on Thursday, those sinusoids, they play a major role in filtration. So if there is some sclerosis going on there or there is some issues going on there with the filtration process, you're going to see blood backing up. And you're going to see blood backing up into that portal vein. Okay? Just kind of FYI, normal pressure in the portal vein is like 3 millimeters of mercury. In someone with portal vein hypertension, you're seeing it at least 10, if not way higher than that. So there's a significant increase in the pressure in that vein. Now, why do we care? Why do we care that there is hypertension and a backup of blood in that portal vein? Let me tell you why. Consequences, right? I talked about this a little bit in my voiceover PowerPoint from Thursday. You will see the backup of blood then, just like you kind of see backup of blood with CHF in the sort of the flow of blood, right? You're seeing backup of blood from that vein, from that portal vein. So where does the blood back up then? If there's hypertension in that vein, where's the blood backing up? Shout out some places where you'll see it back up. Stomach, esophagus, intestines, colon, right? Because that's where the blood was supposed to have drained from, right? The blood's supposed to drain from those organs through that portal vein into the liver. Well, if you've got a backup in that vein, all that blood backs up into all those organs that's trying to shoot it through, right? And so what these varices are basically varicosities. They're varicose veins, right? You will actually see varicose veins in these organs because of this backup of blood from that portal vein. That's not good. Okay, we'll talk about some sort of fallout from varicose veins in these organs in just a second. Splenomegaly is basically just an enlargement of the spleen, again, because of the backup of blood back up into that organ because it's not draining properly into the liver. Ascites, we'll talk about that in a minute, and then hepatic encephalopathy. We'll talk about that in a second. But again, long-term portal hypertension causes very severe pathophysiological problems that are really difficult to treat and very, very much can be fatal. So let's talk a little bit about these varices, this issue of varicose veins in these organs. Okay, so you'll either see, the biggest places that you'll see these varicose veins occurring because of this backup is either in the esophagus, with the greatest percent usually in the esophagus, but you can also see them in the stomach, more specifically the upper aspect of the stomach. And what they basically are varicose veins, this complex of very tortuous, sort of blown out, dilated veins into the esophagus and into the stomach. They contain very little elastic tissue. They're very fragile. Another term we use for these types of varicosities in the esophagus or in the stomach is friable, F-R-I-A-B-L-E. What friable means is that they're very easily broken open. They're very fragile. So anything that's the least bit irritating to that very fragile, big, blown out vein can break it open, can break open these veins. And because of that, these are very, very likely to result in hemorrhage. They're very likely to open up and start bleeding. Why are we so concerned about these upper GI hemorrhages, these upper GI bleeds that would occur because of these broken open varicose veins in, say, the esophagus? What are we so concerned about as healthcare workers, as caregivers for these people, with an esophageal varices that is just broken open? Give me a couple reasons why we're concerned. Huh? Aspiration, right? It's a major airway issue. These things can pour out copious amounts of blood into the esophagus, the back of the airway. We're talking about a major airway / aspiration issue or risk. Good. And what's the other big one? Losing blood, right. So if my arm is hemorrhaging, what do? Put on pressure. If my leg is hemorrhaging, what do? Put a lot of pressure on it. If my esophagus is hemorrhaging, how do we put pressure on that, right? So it's a major hemorrhagic blood loss issue as well. Now, you can see a lot of these triggers for why these varices might get actually broken open. There honestly can just be kind of irritation of the varices, so things like alcohol can be very irritating to these. Poorly chewed or coarse food, so these are people who you do not want to eating a bag of chips or a bunch of nuts, right? Because actually that coarse food can actually rip as it moves down into the esophagus. Acid reflux, the acid can be very irritating. These are not people who you want to be putting down an NG tube. Can you imagine? Just scraping an NG tube down into their esophagus and pulling on that varicose vein. And these are also people who you want to try to decrease the intra-abdominal pressure as much as possible. So, oh my gosh, I remember having this guy who had known esophageal varices coming in, and he started having this sneezing attack in the ER, and I'm like, oh my God, please stop sneezing. I mean, any sort of intra-abdominal pressure, sneezing, coughing, picking up something heavy, vomiting, whatever it may be, can actually break open these varices like that, okay? So how do we treat these? Well, this person, we're trying to get to the OR stat, so to speak. There is actually another sort of quick thing we can try to do in the emergency room that we've seen done before, is putting down something called a Blakemore tube. Blakemore, so spelled exactly how it sounds. This is actually a specific type of NG tube. Okay, and so now I'm contradicting myself, right? So I'm saying don't put NG tubes down on these guys. But once they're actually actively bleeding and you know that they're hemorrhaging, what you do is put down this specific type of NG tube down that has like balloons attached to it, so that once it's down and it's placed, you actually insert air into this particular type of NG tube, and it blows up these balloons to actually cause increased, to hold, basically pressure on the walls of the esophagus, just like you'd put pressure on your arm if your arm was bleeding, to try to stop the bleeding. By no means is it a true fix. It's just kind of a palliative fix, really, until you can get the person to the OR, to sort of tamponade off that bleeding and put pressure on that hemorrhage from the inside of the esophagus. And this person's going to the OR as soon as possible. Yeah. Endoscopy, you would see them a lot, quite oftenly, and really they may not cause any signs or symptoms until they break open, and that's the scary thing, is that all of a sudden this person might just start vomiting bright red blood, right? They're not really vomiting, but it looks like they're vomiting because it's here in their esophagus and coming out. So very, very scary, very life-threatening, very fast. I mean, these people can go down the tubes extremely fast, and we're trying to get them to the OR as soon as possible. Because of that, mortality rate is about 60% or higher of someone who actually has a varices that breaks open. Again, because of the hemorrhage risk, and then also because of the airway risk and the aspiration risk. Okay, 60%, yeah. Okay, and then just as kind of a good picture of why this occurs. So here's that portal vein feeding into the liver, right? And if you've got a backup here, look where the blood backs up. It backs up into the veins in the esophagus. It backs up into the veins of the spleen. It backs up into the veins of the colon and the intestine. So you can actually see pretty large, like hemorrhoidal varices, so really big varicose veins in the rectal area as well, because of this backup in the portal circulation. Okay, and here's a good picture on endoscopy of these. Look how bumpy and sort of tortuous. It's kind of hard to see in here, but this is all very bumpy and looks like a big varicose vein on the inside of the esophagus. It should be very smooth and pink and no bumps really at all. So you can hopefully see how tortuous and how big these varicose veins are in this person's esophagus. Not good, not good. All right. Another big complication of a major sort of liver dysfunction like cirrhosis is something called ascites. Ascites is an accumulation of fluid, sort of serous plasma kind of fluid, in the peritoneal cavity. Remember we talked about that peritoneal cavity as that cavity, that sort of two-layer membrane that covers sort of the entire abdominal cavity and also the organs of the abdomen. You can actually get fluid accumulation in that cavity, just like you did like when we were talking about like pericardial sac, or you can get fluid accumulation in that sac. What happens is that this fluid gets trapped in this third space like we talked about last semester, and it cannot get out. So once the fluid leaks into this peritoneal cavity, it really can't get back up into the circulation. So why? Why does this big fluid accumulation occur in this abdominal cavity in someone with liver disease or liver failure, more specifically? Again, it has to do because of two things. One, the portal hypertension. So we talked about that whole issue of like capillary hydrostatic pressure last semester, where when there's a lot of pressure inside the vessel, that it actually can push fluid out of the vessel into that interstitial space. So if you've got a lot of portal hypertension going on, that can certainly happen around the liver. And where's the liver located? In the abdominal cavity. So where's all that fluid going to go? In the abdominal cavity, right? If it's getting pushed out of the veins inside the liver. The other reason that this happens is, okay, so one, it happens because of increased hydrostatic pressure in the portal vein. Second, it happens because of decreased albumin levels circulating in the blood. So with liver failure, you actually see decreased albumin production because of, so albumin is part of the process is actually sort of created and sort of formed in the liver. So if you've got liver disease or liver failure, your liver is not creating the adequate amounts of albumin. And we know that when you've got hypoalbuminemia in the serum, what does that cause? What does low albumin levels cause? It causes edema. Why? There's less oncotic pressure holding that fluid in, and where does the fluid go? Leaks out into the interstitial space. So it's this combination of portal hypertension and low albumin levels that does not a good combination make. And you have all of this fluid leaking out of the vessels into the abdominal cavity. Okay? So it's this increased capillary hydrostatic pressure and decreased oncotic or osmotic pressure that is a really bad combination, and they just leak like crazy into their abdominal cavity. Does that make sense? So what you see, and maybe, has anyone seen anyone with ascites, taking care of a patient with ascites? Right. You see this profoundly distended large abdomen. So you'll see weight gain, you'll see abdominal distension, you'll see increased abdominal girth. Sometimes if it gets so bad, you'll actually start to see them have respiratory distress and shortness of breath because of how much pressure is being exerted on that diaphragm, and they're not able to sort of breathe to their full extent. And you can actually see peritonitis, so an infection of the fluid sitting in that peritoneal space. Again, treatment for ascites is extremely palliative because really the way you fix ascites from occurring is by fixing the portal hypertension and fixing their albumin level. So you got to try to really get that under control, which is very difficult in someone who has liver failure, right? But palliative, what we can do, and what I see done, again, on a palliative level in the emergency room quite often, is something called a paracentesis. Anyone familiar with that? Where they actually... let's skip here to this page. They actually insert a catheter into that peritoneal cavity where all of that fluid is building up and actually drain some of that fluid off. Again, it's a quick fix. It's only temporary. If you don't fix that portal hypertension and that low albumin, it's just going to build up again. It's just going to happen again as soon as as soon as you take the needle out. It can certainly reaccumulate. And I've seen liters of peritoneal fluid drained off of people with profound ascites. Now the issue with this is that the removal of too much peritoneal fluid can actually cause some problems as well, mostly because the abdominal blood vessels are so used to that increased pressure, sort of creating a sort of tone on their vasculature, that if you take all of that fluid off and you decrease all of that pressure in the abdomen, the vessels kind of just like, bleh, right? And they become extremely hypotensive. So you can actually pull too much fluid off and cause pretty profound hypotension in these people because their abdominal organs and their abdominal vessels were so used to that pressure that when you take that pressure off, they really vasodilate and their blood pressure plummets, right? So you have to be very careful. It's a fine line here between taking off enough fluid so that they can sort of, have decreased shortness of breath and things like that, but not also, causing their blood pressure to go on the toilet. So profound and sudden hypotension can certainly occur. And then here's a picture, if you haven't seen someone with ascites, of what this looks like. I mean, profound abdominal girth and distension in the abdominal cavity. I had a patient in New York who would come in. He was a homeless gentleman. He would come in, I don't know, every so many weeks or so. Again, he was homeless, did not have adequate care for his liver failure, was not getting treated in any way, shape, or form for his liver failure, other than coming in every so often to get a paracentesis because his abdomen would look like this. Really, really sad situation. He would come in respiratory distress, and we would just have to do a paracentesis for him to be able to breathe. Again, lack of care, lack of any sort of connection to anyone to get his actual liver failure treated. He was an alcoholic, and that was sort of the sad thing, is that he would come in for his paracentesis because of his cirrhosis, drunk as a skunk. I mean, like, he'd just be completely, completely intoxicated coming in to get this paracentesis. So it can be some really sad clinical situations that are sort of affiliated with this type of liver failure to this point where they're so acidic, have ascites. Yeah?
Is this something that can happen acutely, or does it happen more gradually?
It usually is going to happen after pretty profound liver failure, where you've got, again, that bad combination of portal hypertension and hypoalbuminemia.
But
Yeah.
will it be like something that like an overnight buildup?
It'll be a little bit slower than that. Yeah, so like this guy in the ER in New York, it would take several weeks for it to sort of build up again. But again, it sort of depends on their clinical course and how profoundly their liver's affected. Yeah. Yeah. Yes, and that actually is one of the, so not only, she said, can IV albumin be used to sort of help? It's not going to take the fluid off, but it can certainly help from reaccumulation, of using IV albumin to get that albumin level up, to help with that oncotic pressure inside the liver and inside that portal vein. Yes, very, very good, right. But again, it would have to be sort of a continuous sort of, supplementation of albumin in someone with liver failure because their liver just isn't able to sort of regenerate and create that albumin on its own. Good thinking, yeah. All right. All righty. All right, next one, hepatic encephalopathy. This is also a really fascinating clinical manifestation of profound complications of liver disorders. Hepatic encephalopathy occurs because under normal circumstances, our liver sort of clears some of these toxins from our blood, right? And the biggest toxin associated with encephalopathy is ammonia. So ammonia is actually a byproduct of a lot of cellular functions and cellular metabolism in our body. It's also a byproduct of muscle activity, so muscle metabolism and those types of things. It's also a byproduct of bacteria. So bacteria can actually release ammonia as well. So under normal circumstances, when our liver is working appropriately, our liver clears all that ammonia out and takes it out of our blood, right? When your liver is not working because of cirrhosis or liver failure, it doesn't do that. So what you see is ammonia levels in the blood, in the serum, build up and build up and build up and build up. So you have these wicked high levels of ammonia in the patient's serum. And what happens is this ammonia crosses the blood-brain barrier in the brain. And again, I will tell you, ammonia in the brain, not a good combination, right? It's extremely neurotoxic. So what you start to see in patients that have this profound buildup of ammonia is you start to see some really profound neurologic changes, profound level of consciousness changes. So you'll see changes, it can, again, run a spectrum of kind of some subtle personality changes or some subtle sort of sleep disturbances, all the way to very profound confusion, very profound loss of consciousness, stupor, coma. And again, it's basically because ammonia is extremely neurotoxic to the tissues of the brain, right? You can imagine having a bunch of ammonia sitting in your brain. Not a good combination, right? Extremely toxic to those tissues. So again, it happens because of this lack of filtration of ammonia out of our blood. Now, how do we treat it? There's several things we can do to treat hepatic encephalopathy. One, you can actually use antibiotics to try to sterilize the bacteria in the GI tract. Again, because ammonia can sort of be a byproduct of bacterial growth. So if you decrease, even just decreasing the normal flora in someone's gut, you can actually decrease their ammonia levels. Another thing you can do is actually trying to put this person on more sort of bed rest or kind of modified bed rest because, again, muscle metabolism and muscle breakdown can actually increase ammonia levels. So you want to try to decrease their physical activity to try to decrease the ammonia levels in any way you can. The third way that you can try to decrease ammonia is by giving something called lactulose. Again, this is a resin that actually binds to the excess ammonia in someone's gut. And then they actually get rid of that excess ammonia through large, sort of copious amounts of diarrhea, through stool. And I have seen lactulose be extremely effective in the emergency room, where someone comes in, maybe A&O times 1 because of hepatic encephalopathy, give them a dose of lactulose, and within an hour or so, maybe a little bit more, they're completely coherent, A&O times 3, talking to me like you and I would be talking. So it can be extremely effective. Again, it's short term because that ammonia is just going to build up again. So oftentimes people with this type of liver disease and with a known history of encephalopathy will sort of just do daily lactulose. But again, it does cause pretty profound diarrhea. And again, I will tell you, again, I try to always bring it home a little bit here in this class and sort of talk a little bit about the real world implications of lactulose. It's easy to stand up here and say, oh yes, so you fix hepatic encephalopathy by giving lactulose. Lickety-split. Can you imagine the ramifications of giving someone who is completely disoriented, confused, A&O times nothing, A medication that's going to cause profound diarrhea. Yeah. So as a nurse, anytime I ever hear of like, okay, we're going to order some lactulose, I'm like, oh God. I have a situation in the emergency room in St. Louis where we had this guy. It was not my patient. It was one of my nurse colleagues who was completely, and I don't mean to be insensitive, but completely out of his mind. I mean, A&O times nothing, couldn't even speak, like just guttural sounds, was pulling out his IV, trying to climb over the bed rails. I mean, just trying to take his gown off and walk up and down the hallways. I mean, just completely neurotoxic. I mean, poor guy. He was completely neurotoxic from this ammonia level. So, of course, what do they order? Lactulose. I will never forget, and it was not my patient, but I couldn't let my poor nurse friend go do this by herself. A half hour, hour or so after the lactulose administration, look in his room, everywhere. Everywhere. All over his stretcher, all over the walls, because he was like in it and touching it, and I mean, hazmat. I mean, literally dangerous hazmat. I was like, okay, well, you're not going in there by yourself, and we have to fix this. So we literally like gowned up, and of course this, you know, you can imagine how it smelled. Gowned up, like hazmat, mask, everything. Smelled so bad, we ended up, the dinner trays had just come. We ended up taking the tea bags off of the dinner trays and sticking them down in our masks so that we could sort of breathe the tea leaves instead of breathing the air. But extremely profound diarrhea. And extremely dangerous, because not only was this man, I think he had encephalopathy because of, you know, chronic alcohol use and that type of thing, but he was also he also had AIDS, so it was also extremely dangerous in terms of getting him cleaned up and getting the room cleaned up and getting him cleaned up. And I'll never forget ever when I think of lactulose what it does, and now you'll never forget what lactulose does either, right? To say the least. So that is lactulose and encephalopathy in a nutshell for you. Yeah. Yeah.
You know how when you go into kidney failure, you go on dialysis?
Yeah.
Is there any kind of similar treatment?
Like filtration of the liver? No. No, there's not. It's all of these sort of palliative treatments that you try to do. There really is no fixing it other than a liver transplant. Yeah. Yeah. Yeah, one more question.
Those neurotoxic effects become permanent?
It can be. In fact, I think this guy was probably a little bit that way, in that his neurotoxic effects were permanent. I don't know if this guy was going to get back to baseline after lactulose. Yeah, good question. Okay, real quick here. The other, obviously, complication of a liver disorder is jaundice. We've talked about that a lot. We're not going to sort of spend time on this slide just because we've kind of talked about the pathophysiology of why jaundice occurs in these patients. And there's sort of the flow sheet for you. And then last but not least, I'm not going to touch on this super long either, but what I really want you to understand, and we'll talk more about this syndrome actually when we talk about the renal disorders later on this semester, but what I want you to understand is because you've got all of this sort of hypertension going on in the circulation to the liver, and or you've got all of this fluid leaking out of the circulation into the abdominal cavity, you actually see, okay, so if all your fluid is there, or in and around the liver, or out into the abdominal cavity because of ascites, what are you going to see in terms of circulation to the rest of the organs in the body? Decreased perfusion, basically, to the rest of the organs. So you actually see something called hepatorenal syndrome, and that you actually can kind of start to see these patients go into renal failure as well because of lack of flow, lack of blood flow, lack of oxygen, lack of, perfusion to the tissues of the kidney. And that's basically what hepatorenal syndrome is. We will talk more specifically about that type of renal failure when we talk about the kidneys in a little while. Okay, but I just want you to understand that. Okay? All right. Any questions about the liver before we go quickly here now? So I'm going to stop here because we're going to, then if you look at slide 54, we go into sort of like accessory organ, like disorders of the gallbladder. That stuff's pretty self-explanatory. So what I'm going to do is, okay, stay with me here, follow me. I'm going to go back up to the top of the lecture now, because remember I said I wanted to do the liver stuff first while we were fresh. So we did that. Now we're going to go to the beginning of the lecture and talk a little bit more about some more sort of basic gastrointestinal abnormalities for the next few minutes here before class is over. All right, stay with me here. Okay, so we're leaving the liver discussion. We're moving to more general GI issues. We'll speak about this for the next few minutes, and then there'll be a short voiceover regarding some of the other stuff at the end of the lecture, like from, slide 54, the gallbladder, and on, okay? GI bleeding. You can either have GI bleeding on the sort of upper GI, which is what we consider the esophagus, the stomach, or the first part of the small intestine, the duodenum, or you have GI bleeding going on in the lower part of the GI, so the end part of the small intestines, the jejunum. You okay? Just don't want anyone like passing out and falling on the floor. Anytime I hear that thud, I'm like, oh my God, who passed out? All this GI talk. All right, so jejunum, ileum, smaller part, like the end part of the small intestines, and then obviously the colon and the rectum are what are we considered the lower GI. If there is bleeding going on in the upper GI, often, like especially like in the esophagus and this upper part of the GI, it's oftentimes characterized by frank, bright red, obvious blood, right? Oftentimes, though, it's not so obvious, and you get what we call coffee ground emesis. And coffee ground emesis is exactly what it sounds like. If you've ever, when you're taking out your old coffee filter out of your coffee machine and you're throwing it in the trash before you make your new pot, and you see that the way that the coffee grinds look after they're wet, right? That brown, granular, kind of wet, sludgy looking stuff. That's what coffee ground emesis looks like if someone's throwing up what we call coffee ground emesis. Why would that be? Why would their vomit look like that instead of bright red, frank blood? It's been partially digested. The acids in the stomach sort of break down the blood, and that's what partially digested blood looks like, right? And so it looks more like coffee grounds than it does bright red blood. So if you see coffee ground emesis, okay, the bleed is probably a little bit lower down, maybe in the stomach, because it's been in contact with the acids of the stomach, as opposed to the esophageal bleeds, who are just going to look frank, bright red blood, because it hasn't been digested. Lower GI bleeding will look more like what we call melena, and that's usually not coming up from the top. Someone who's bleeding from their lower GI is usually not vomiting. They're usually losing blood per rectum, right? So they can either look like black, tarry stool, that's what we refer to as melena, and again, because the blood has been partially digested in the GI tract, so it has that black, tarry look to it. Or what we call hematochezia, which is bright red blood per the rectum. That's usually more because of like hemorrhoids or something at the very end of the GI tract right at the rectum, because again, it's bright red blood. It hasn't been in contact with the digestive juices of the GI tract. So again, the color, I know this is lovely to talk about, good morning conversation right before lunch, but the color and the quality of the kind of bleeding that you're seeing can give you a little bit of an indication of where the bleeding is coming from per, what we've just talked about here. The other type of bleeding that can occur in the GI is more of your sort of occult bleeding. And what I mean by that is you don't necessarily know that you're bleeding. It's not obvious. So maybe more of a slow, chronic blood loss occurring at very slow progression of time. Maybe because of a polyp, maybe because there's some cancer going on there that's causing small amounts of bleeding. So you don't even know that you're bleeding, but you do a CBC and you're like really anemic. You're really low in terms of your red blood cells. They're going to start to look for more of occult reasons for why you might be bleeding and why there might be this decrease in red blood cells. So that is sort of more of your definition of occult GI bleeding. Okay. Again, not going to spend a lot of time on this, obviously, because if you're losing blood, I hope at this point in your education that a lot of these physiological responses to being hypotensive are pretty apparent to you. But as you can imagine, depending on how much blood you're losing and at what rate of time that you're losing this blood, GI bleeds can be quite life-threatening, depending on the volume and the rate of blood loss. And then, of course, changes in your blood pressure, changes in hypotension, et cetera, et cetera. Okay. All right. To finish up, we're going to finish up just a couple more slides here for today. And in the discussion, just starting to talk about disorders of motility. So the first thing we're going to talk about in terms of motility issues in the GI tract is something called dysphagia. You may or may not know that dysphagia basically means difficulty swallowing, the difficulty of the actual swallowing mechanism. It can be more of a mechanical problem. So let's say there's a tumor or there's a stricture or there's something going on in the esophagus that creates difficulty in swallowing. Or it also could be more of sort of a functional sort of neurologic reason for why someone might have difficulty swallowing. So it's not uncommon after someone has suffered like a stroke, a CVA, to have neurologic deficits in their sort of back of their throat, pharynx, mouth area that could cause difficulty swallowing, or any other sort of like neuromuscular degeneration, like the ALS patients that I told you about that I worked with. They have a lot of dysphagia because of lack of neurologic innervation to the back of their throat. Again, could be one reason or another. It could be an actual problem or an actual structural issue with the ability to swallow, that like a tumor is blocking the ability to swallow, or you've just got a weakness or a lack of neurologic innervation that doesn't allow them to swallow. Either way, it's dysphagia. Either way, it's difficulty in swallowing. And again, just wanted to sort of briefly mention that definition because you will certainly hear that when you're discussing both GI, but also perhaps neurologic conditions that you hear in clinical and et cetera. Another disorder of motility is something called achalasia. This is characterized by a loss of esophageal peristalsis. So again, that movement of the esophagus to pull food down does not work properly. And it also can be because of a failure of that lower esophageal sphincter right before it enters into the stomach, a failure of that sphincter to relax. So you have like an actual obstruction or a stricture around there. So you can imagine as you swallow food and it's not able to pass through that sphincter, what happens? The food just keeps backing up, backing up, backing up, backing up into the esophagus. Extremely uncomfortable. Patients complain of this very sort of severe stabbing pain at the level of wherever the stricture is, sort of in their chest. It might make them sort of regurgitate or actually vomit because the food has nowhere to go but back up because of this stricture in their esophagus. Vomiting because of vomiting aspiration. And then obviously because you're not getting food down into the rest of the GI tract, you're seeing some profound weight loss and other sort of nutritional deficits in these people. Treatment can sort of range on a spectrum from, okay, just teaching the person to sort of eat smaller meals, take smaller bites, drink a lot of fluid with their meals to kind of allow for the passage of that food through that stricture, sleep with the head of the bed elevated a little bit, etc. A more sort of invasive treatment or fix for this problem, this disorder of motility, is to actually go in, sometimes endoscopically, sometimes surgically, and actually blow up and sort of dilate and stretch that lower esophageal sphincter a little bit to allow for the passage and the movement of food through that stricture, through that obstruction. So again, that is the true definition of achalasia and certainly a disorder of motility in the GI tract. Here's a good picture for you. Here's the lower esophageal sphincter. You can see how it gets restricted here. And then what you'll start to see is sort of a blowing out or an increased volume, so to speak, of the esophagus here because of food actually sort of sitting here and getting stuck and not able to pass through. Again, this is what causes that discomfort and that chest pain. And obviously then the regurgitation. Okay. All right, we are going to stop there, so follow here with me for a moment. The rest of the slides of disorders of mobility, so if you look here at your slide, you see GERD, you see hiatal hernia as another example of disorder of motility, and you see pyloric obstruction. Those are the next few slides. Okay, listen closely, just cross those out. Don't have to worry about those, okay? Cross the rest of those motility issues out that I just mentioned. Up until you get to the disorder of mobility slide that talks about intestinal obstruction and paralytic ileus. I do want to go over that with you. That is important. It's information and content that I want you to be familiar with. So I will do a quick voiceover PowerPoint on that, starting with disorders of motility, intestinal obstruction, and paralytic ileus, throughout the rest of the content of this lecture. So talking about ulcers, inflammatory bowel disease, irritable bowel disease, and then some of the gallbladder stuff at the very end. Does that make sense? Okay. So again, cross off GERD and hiatal hernias, and I will pick up with you on intestinal obstructions and paralytic ileus. Okay? All right. Do remember that we do not have class this coming Thursday, and we do not have class the following Monday, right? I told you about that on Thursday. The voiceover PowerPoints for your reference and to have on that content will be up by the end of the day today for you to listen at your own rate and your own pace. I will see you a week from today here in class. No. A week from Thursday. Sorry. You know what I meant. Don't want to confuse you. I'll put a reminder on my Friday note.